who recently underwent redo abdominal aneurysm repair. This is a 56-year-old Hispanic gentleman who recently underwent redo abdominal aneurysm repair and rectosigmoid colectomy with colostomy due to infected abdominal aortic graft and large bowel fistula. His clinical course has been complicated by left renal vein and left femoral artery thrombosis, for which he underwent left renal vein ligation and left femoral artery thrombectomy. Additionally, he developed right hydronephrosis and a right nephrostomy tube was placed, and he is currently being treated for MSSA. He is currently 17 days post-op. Past medical history includes hypertension, dyslipidemia, CHF, type 2 diabetes, paraganglioma, and hypothyroid. Past surgical history includes retroperitoneal paraganglioma resection times 2, AAA repair, ligation of left renal vein, repair of infected abdominal aortic graft with large bowel resection, femoral thrombectomy, and nephrostomy. Social history: he is disabled due to chronic illness. He does not smoke or drink. Family history: his parents are deceased. He has several brothers and his sister who reside in Mexico that he has not seen for several years. He is married. His wife works outside the home, and he has a son in college. Meds include aspirin 81 milligrams q-day, Lipitor 80 milligrams q-day, lisinopril 2.5 milligrams q-day, carvedilol 12.5 milligrams q12 hours, furosemide 40 milligrams q-day, doxazosin 4 milligrams q-day, levothyroxine 125 micrograms q-day, Protonix 40 milligrams q-day, heparin 5,000 units sub-q, q8 hours, Plavix 75 milligrams q-day, Docusate sodium 100 milligrams QHS, ceftriaxone 2 grams IV Q12 hours, fluconazole 400 milligrams IV Q8 hours, lidocaine 750 milligrams IV daily, flagyl 500 milligrams IV Q8 hours, gabapentin 300 milligrams Q8 hours, tramadol 50 milligrams QHS, acetaminophen 1,000 milligrams Q6 hours, Zofran 4 milligrams Q6 hours IV, Biscadil 10 milligrams POPR Q-day, PRN, NPH insulin 20 units, QAM 10 units, QPM subcutaneous, and R insulin via sliding scale. Labs today include white count 8.1, hemoglobin 8.5, hematocrit 27, platelets 372, sodium 136, K3.6, chloride 101, CO2 26, BUN 31, creatinine 1.0, glucose 135, TSH 4.1. Review of systems. In general, he complains of fatigue and weakness. HEENT denies headaches, otalgia, vision change, sore throat, or neck pain. Respiratory denies hemoptysis, dyspnea or arthropnea. Cardiovascular denies chest pain or palpitations. GI denies nausea or vomiting, complains of stomach tenderness from nephrostomy and colostomy sites. He reports that he is not passing much stool via colostomy, but he indicates that he is passing gas. GI denies hematuria, and he states his catheter hurts at times. Musculoskeletal complains of left knee pain and left foot pain. Skin denies itching or rash. Neuro denies dizziness, tingling, or tremor. Psych acknowledges some depression. Physical exam, vital signs 37.0, 102, 16, 115 over 74, 97%. General, this is a chronically ill appearing middle-aged man who appears older looking than his stated age. HEENT, pupils are equal and reactive to light, sclera and icteric. Conjunctiva, pale and moist. Oral mucosa, tongue and lips are dry. Gums are pale. Teeth are in decent repair. An NG tube is located in the right ear. NG neck, supple without lymphadenopathy or goiter. Cardiovascular S1 and S2 are noted at regular rate and rhythm. 2 plus edema is noted to the lower extremities. Pedal pulses are via Doppler only. Capillary refill is brisk. Extremities are worn. Respiratory, lungs are clear to auscultation, and chest excursion is equal. GI colostomy appliance is noted to the left lower quadrant, and a nephrostomy tube is located to the right lower quadrant. Midline abdominal incision is open to air and will approximate it without drainage or irritation, and surgical staples are intact. There is a small amount of green-black stool noted to the ostomy appliance. The stoma is pink and healthy. There is a small amount of clear drainage noted to the nephrostomy device. Abdomen is slightly distended and acidic in appearance. He is receiving TPN. GU, if Foley catheter is in place, it is draining clear yellow urine. musculoskeletal. The fourth and fifth toes of his left lower extremity are necrotic. There is a clear line of demarcation along the proximal knuckle line to each toe. Skins without rash, lesion, or ulceration. Neuro, alert, oriented, appropriate. Cranial nerves 2 through 12 are intact. Sight, mood, and affect are flat and apathetic. Impression, this is a chronically ill, middle-aged man following a complicated course after major abdominal surgery. He is now 17 days post-op. He is being followed by neuroendocrine service for paraganglioma, cardiology for hypertension to CHF, vascular surgery for AAA, renal vein ligation, and femoral thrombectomy. He is also being followed by infectious disease for a chronic MSSA infection. Plan for him includes hypertension, stable on coregulosinopril, CHF, suplex edema. Will discuss the cardiology for possible increase in Lasix. Hypothyroid is stable, continued levothyroxine. Paraganglioma is stable, continued doxycycline for alpha blockade, and carvedilol for beta blockade. Neuroendocrinology is following. DM2, continue exogenous insulin replacement while on TPN. Will transition to oral meds for home routine when tolerating PO. AAA repair is stable, only 17 days post-op. That outside is healing well. Will remove staples today and apply steroids. He is on Lovenox and Plavix with vascular surgery following. Colectomy, colostomy. Stoma is pink and healthy. There's a small amount of stool noted. He is passing gas via the colostomy. Nephrostomy will discuss with urology today for possible removal of tube as it has not drained. Significant drainage in several days. VTE, his fourth and fifth toes are necrotic and expected to auto-amputate. Vascular is following. There is little concern for gas gangrene at this point. MSSA, he's on levaquin, Rocephin, and Flagyl. Will require long-term IV antibiotics following discharge. ID is following. Nutrition, passing gas via colostomy, remove NG tube, continue TPN, add clear liquids. Chronic illness and debilitation, physical therapy, occupational therapy are following for strengthening. Depression, add Zoloft to consult clinical psychology. Disposition, discuss with care coordination for transition to LTAC versus SNP or rehab. Thank you. This concludes webcam case presentation number 1 by Patrick Pruitt.